Hello, everyone, and thank you for joining us. This is Aisha Taylor Kamara with JBS International. And before we begin today's session, I'd like to review some housekeeping items. Please note all audio connections are muted at this time, and we ask that you please keep your lines muted for the duration of this session. If you have any questions or comments, please submit them by using the chat feature located at the bottom center of your Zoom window or in the Hoover chat on the right side of your screen. Questions will be addressed during the Q&A segment at the end of the presentation. If you experience any technical issues during the session, please message the host using the chat feature. Lastly, this is a recorded event and your participation grants consent to be recorded. The recording of this session and PowerPoint slides will be available and sent to all participants at a later date. And now I will turn it over to Monica, who will introduce our speakers.
Sure, thank you. Hello, everyone. My name is Monica Rousseau with the Federal Office of Rural Health Policy, and I, along with John Roberts, will be your moderators for this session, which is titled Considerations for Addressing Neonatal Abstinence Syndrome. It is my pleasure to briefly introduce our outstanding group of speakers for this session. Please note that their full bios can be found in this session's description under the agenda on the Hoover platform. So I will not be introducing them with full justice. Their backgrounds are extensive. So this is an abridged format. We have Erin Lopata, who joined HRSA as the Maternal and Child Health Bureau's Chief Medical Officer and has been serving in that role since November 2014. We have Kari Earle, who has worked with states, tribes, local governments, and nonprofits all over the country to help them identify and apply multi-system collaborative solutions to challenging health and human service problems impacting the most vulnerable and underserved people in communities, and currently works with JBS. We have Colette Weatherstone, who has been with the Coteau de Prairies health care system since 2010, working in various roles and projects regarding the promotion of health and wellness, population health, and other areas. We have Linda Littlefield, who has been with the Great Plains Tribal Chairmen's Health Board since 2014, where she serves as the principal investigator and project director of the Great Plains Healthy Start Program, a HRSA-funded project serving American Indian mothers of childbearing age and their children living in rural tribal communities. We also have Jillian Fabricius, who oversees strategic initiatives at Illuminate Colorado, including managing the Colorado Substance Exposed Newborn Steering Committee and associated work groups. Finally, we have Dr. Maren Wright Voss, who has an MS in psychology and an SED in health sciences. She is a pilot faculty member in the Health Extension, Advocacy, Research, and Teaching Initiative at Utah State University Extension. Again, it is my pleasure to introduce this group of impressive speakers. As many of you know, I am the coordinator of the RCORP Neonatal Abstinence Syndrome Program. I hope you find this session very informative and helpful for all of you. And with that, I will turn it over to our first speaker.
Great. So again, my name is Erin Lopata, and I'm the Chief Medical Officer for the Maternal Child Health Bureau at HRSA. Short for MCHB, I'll be using that acronym a lot. And the purpose of this presentation is really just to familiarize everyone with MCHB's programs and resources that serve families impacted by opioid use and neonatal abstinence syndrome. Next slide, please. So the first thing I want to talk about is MCHB's mental and behavioral health investments aim to improve detection of maternal and child behavioral health conditions and promote access to behavioral health care and enhance the capacity of the maternal child health workforce to meet families' behavioral health needs. And along the public health continuum, MCHB's investments also promote the integration of behavioral health into primary care and support frontline providers as they screen, assess, refer, and treat two generations of parents and children, linking them to care and family supports. And to do all that, MCHB sort of breaks everything down into three different groups. We serve, provide grants at a systems level, we support providers at the provider level, and we also try to support policies across the country as well through our program supporting state maternal and child health policy innovation, which is called MCH PIP. So we have a systems level support, national, state, local, provider level, and policy level. Next slide, please. So at the systems level, I just wanted to give you some examples of the programs we have at national, state, and local levels. And also note that there's a lot of overlap here. So for example, the national level, we have, what I'm sure a lot of you know about, our Title V MCH block grants that go to states. And we also have MCHB's home visiting program, also known as MCV, for maternal, infant, early childhood home visiting program. And our 2020 CARES Awards, which were for telehealth to increase access to telehealth. At the state level, we support screening and treatment for maternal depression and related behavioral disorders, and grants the state to support pediatric mental health care access. And at the local level, we have a program called Rural Health Impact, which I'll discuss in a couple slides, and the Healthy Start program, which I'll also discuss. Next slide, please. So at the provider level, we have example, again, Healthy Start it's local, but it's also, the grants we provide for Healthy Start also serve providers that provide direct services through home visits. So Healthy Start's another example for service delivery. And then the home visiting program, again, it's a grants to states, but states fund programs that provide home visiting direct services to families. And I'll describe that a little bit later as well. And then we also provide at the provider level training through collaborative office rounds, leadership education in adolescent health, which is our LEA grants, and supporting fetal alcohol syndrome screening intervention program. These are just examples. We also fund and support quality improvement and guidelines, such as the Alliance for Innovation on Maternal Health, AIM, which I'll also discuss a little bit later, and Women's Preventive Services Initiative, WIPSI, along with Bright Futures, which I'm sure many of you are also aware of. Next slide, please. So just to discuss some of the programs I mentioned above, in more details, these are the programs that at the provider level that provide services to families that are at risk of or experiencing opioid abuse or neonatal abstinence syndrome. The first one I want to talk about is Rural Health Impact, which stands for Rural Health Integration Models for Parents and Children to Thrive. It's a lot of words. So Rural Health Impact is the impact is the acronym. And these grants go to local rural communities to help them implement evidence-based two-generation strategies that promote health and well-being of children prenatally to age 3, that really critical age, and create economic opportunities for their families. So it's a two-generation approach to serve the children and the families. And Rural Health Impact has a focus on children diagnosed with neonatal abstinence syndrome or other prenatal substance exposures and their families. The other program that does a lot of this work, similar work, is the Maternal, Infant, Early Childhood Home Visiting Program, which supports voluntary evidence-based home visiting services for at-risk pregnant women and parents with young children up to kindergarten entry. Now, these home visitors screen, educate, and connect perinatal women and newborns to treatment and recovery support services. So they do a lot of direct services to high-risk women and families as well. And they also created a resource called Supporting Families Impacted by Opioid Use in Neonatal Abstinence Syndrome. And the resource was created for MCV grantees, but it really can be used for any home visitors or community health workers. Next slide, please. Another key MCHB provider level program is the Healthy Start program, which many of you or some of you may know about. This also provides grants to support community-based strategies to reduce disparities in infant mortality and improve perinatal outcomes for women and children in high-risk communities throughout the nation. Healthy Start home visitors also screen, educate, and connect perinatal women and parents of young children to treat and recovery support services, to treatment and recovery support services. So Healthy Start also works directly with families and women who are at high risk for substance abuse and other high-risk issues as well, whether it is low poverty or being single mothers. This is the high-risk population Healthy Start serves. And Healthy Start also created resources as well. The Alcohol Substance Exposed Pregnancy Prevention Initiative. And this initiative developed training materials to inform Healthy Start grantees understanding of the impacts of fetal exposure to alcohol, opioids, and other drugs, and to strengthen their capacity to engage in effective prevention and early identification activities with pregnant women, mothers, and newborns. And again, while these materials were developed for Healthy Start staff, they can be used by all community health workers and home visitors and health service agencies who serve pregnant women. So everybody should be free to share and use those resources. And I'm going to have, at the end of this last slide, we'll have a link to all these resources as well. Next slide, please. So these are an example of the Healthy Starts Alcohol Substance Exposed Pregnancy Prevention Initiative materials that they've created that should be used, that can be used by anybody. One, they have created a quick start list on opioid and behavioral health resources, which is a compendium of resources that covers everything from policy papers to training to community awareness campaigns and other tools. They also created staff development resources for groups, which include staff training packages and group discussions to guide increased knowledge of opioid use during pregnancy. And they also created self-study resources, which includes a study guide on state legislation on substance abuse during pregnancy and an e-learning course, alcohol and substance abuse pregnancies. So a lot of resources are available for this. And finally, they create resources on substance use during pregnancy in tribal communities. And this includes a compendium of tribal behavioral health resources and an infographic on social determinants of substance use during pregnancy in tribal communities. And you can find this on the Healthy Start Epic Center website. And again, I'll include that at the end of the presentation. Next slide, please. Sorry, one second. So these are a couple of other MCH funded resources. Mother2baby.org. This site provides free, confidential, and up-to-date information about medications and more during pregnancy and breastfeeding via phone, text, or email. This is a great resource. And they've also developed fact sheets specific to 10 different opioids or narcotics that provide information on the effects of these agents during pregnancy and while breastfeeding. And again, I will provide the links to this and the numbers at the end of the presentation. We also have the Alliance for Innovation on Maternal Health, AIM program. This is a quality improvement initiative focused on reducing maternal deaths and severe maternal morbidity that helps us work with state-based teams to implement evidence-based bundles to improve maternal safety and outcomes. And in August of 2017, the AIM program released the Maternal Safety Bundle on obstetric care for women with opioid use disorder. And next slide. And then there's a couple of, these aren't MCHB specific, these are just HRSA broadly funded resources. And just recently, HRSA's Office on Women's Health funded a new resource, Caring for Women with Opioid Use Disorder. And this is a toolkit for organization leaders and providers. And you can see the link to the website here. I included on this slide. Also with HRSA support, the National Academy for State Health Policy released a report in 2018 for state options for promoting recovering among pregnant and parenting women with opioid or substance use disorder. And so you can find the link here. And that's also a great report for state level officials. And this is a link to all the resources I discussed above. The first link is to MCHB's website on behavioral health generally. But then this is the Healthy Starts initiative, which provides resources that I discussed above. And also the home visiting programs supporting families impacted by opioid use and neonatal abstinence syndrome and mother to baby as well. So again, it's a lot of resources, but just gives you an idea that NCHB supports families that are affected by opioid use and neonatal abstinence syndrome by supporting policy at the state level, by supporting identifying best practices and providing resources for providers and state level and policy officials, and by supporting programs that provide direct services to families that are affected by opioid use and neonatal abstinence syndrome. So that's it. That's my presentation, but I'm looking forward to the larger discussion as well. Thank you so much.
Thank you so much, Dr. Lopata. I love those resources that you highlighted and have used them a lot. I think we all have as TELs and the grantees as well. So for any of those of you who are participating today and haven't seen some of those, definitely worth checking out. They will help you, and also even if you're not a state but working at the grantee level, it nonetheless helps to see what those state policy recommendations are, so that you can kind of track what's happening in your state to support your work. So I am excited to introduce you to our panel. These are grantees in regions 8, 9, and 10 who are funded to work on the NAS grants. And they are just wrapping up their 6 months of planning. They'll be wrapping that up in March and starting implementation in April. And so we've invited them to talk to you about specific aspects of the work that they're engaging in and how they're doing that work. And we've got some targeted questions that we'll kind of walk through, and we'll have plenty of time at the end to really get into a broader discussion with a lot of participant involvement, we're hoping. So as you're listening, I would encourage you to queue up some questions. And if you can go to the next slide. I am going, these are our presenters and our grantees. We do have a 5th RCORP NAS grantee, UC Davis, that was unfortunately not able to participate today out of Region 9. So than me walking through their slides, we're going to take about 15 to 20 minutes for them to tell you a little bit about their projects, just to provide you the additional context that they're working in, both regionally and from a project perspective. So Colette, I'll hand it off to you.
Yes, thank you, Kari. So as Kari said, my name is Colette Weatherstone, and I'm with Coteau de Prairies Hospital, our healthcare system located out in South Dakota. We're up in the northeastern corner of South Dakota on this community of Sisseton, which is a little over 2,000 people live in this area. We're located in Roberts County, which has a population of about 10,000 people. We're also located on the Sisseton-Wahpeton Reservation. We are the only hospital within our county. We're a 20-bed critical access hospital. And then there's also Indian Health Service clinic located in our community. So we do a lot of partnering with them two groups.
There's a second slide that conveys the way that each of these grantees in their applications were asked to select a specific focus area and then 2 strategies each for prevention, treatment, and recovery. They could have selected more if they wanted, but a minimum of 2. So Colette, do you want to walk us through that very quickly?
Sure, yes. We selected the strategy under prevention of increasing access to family planning and also coordinating evidence-based services and education to our population. With under the treatment selection, we chose the strategy to educate key groups on best practices and how to improve and engage people on early intervention. So again, targeting those moms early within their care. We also want to increase access to behavioral health by establishing and improving service models unique to the needs of our target population. As many of you probably experience the same thing, we have sometimes barriers on accessing behavioral health in our area, so that it's something we definitely wanted to have strategies with. So, and then finally, we also for recovery, improving the understanding of stigma and knowledge base within both our community and staff, and enhancing the coordination within the target population. So those are the areas we plan to focus on, and eager to get to work.
Thanks so much, Colette. And you all be hearing more about different aspects of the work that they're doing as we get into the questions. But if you want to switch to the next slide.
Good morning. Thank you. I'm Linda Littlefield, and I am I work for Great Plains Tribal Chairmen's Health Board. As stated in my bio, I manage the Great Plains Healthy Start program, which has been one of the original Healthy Start programs in the country. We've been funded since 1992 for that program, and I serve on the consortium for this RCORP grant. And it's a wonderful opportunity. We're very excited about it. The Health Board, just for your information, the Health Board serves all 17 tribes in the Great Plains area, which is Iowa, Nebraska, North Dakota, and South Dakota. Our RCORP project is located in Crow Creek, South Dakota, which is a small reservation in the central part of our state. And next slide, please. This slide shows our focus area in preventive strategies, in treatment strategies, and in recovery strategies. In preventive strategies or prevention strategies, we chose to address reproductive life planning or access to family planning services. We knew this was an important area for us because in 2017, the Health Board conducted South Dakota's second tribal PRAMS or pregnancy risk assessment survey. And we learned that in the 2017 PRAMS, we learned that 36.5% of pregnancies for American Indian women in South Dakota were ill-timed. 14% were unwanted, and 32% were unsure if they wanted to be pregnant. Yet 82% who were not trying to get pregnant were not using birth control. And 32% of those not using birth control did not think that they could get pregnant. So we knew this was an important issue. We also knew that there were several areas or programs in the Crow Creek community where these services were available. The education was available through different projects, including our Healthy Start program there. And we knew that we had an opportunity here to coordinate those services, kind of get rid of silos, if you will, and really work at a systems level to bring providers together, to bring programs together, and really address reproductive life planning. So that's why we chose that. And also, of course, that is coordination of services and education. In treatment strategies, we looked at Crow Creek in the sense that there are no MOUT waivers in that community. It is a HRSA, a healthcare provider shortage area. It is also a behavioral health provider shortage area. There is an IHS clinic there, and there is one private behavioral health provider in that community that provides telehealth services, but there are no inpatient treatment facilities in that community. And so we knew that we could make a a strong impact and build capacity by addressing the lack of MOUT waivers, by helping to encourage medical providers to be involved in serving women and their families who struggle with substance use disorders. And we knew that we could also address some of the physical barriers to access to care through the addressing of childcare on a community level and the need for, of course, outpatient services. And so that is our focus area for treatment strategies. I learned some interesting things in this process in thinking about accessibility. According to the National Academy of Medicine, there are in the United States, which has a population of 320 million people, there are fewer than 2,000 board-certified addiction psychiatrists and 2,500 physicians certified in addiction medicine. Fewer than 10% of physicians in the US have completed the training required for prescribing buprenorphine, and only 7% of physicians have received DEA waivers. So we knew that was really an important area for us to work. And then for recovery strategies, we really, again, wanted to look at the community as a whole, recognize that one size does not fit all, think about harm reduction, think about peer support, and think about community response to people who are in recovery. And so that's our focus. Thank you.
Thank you very much, Linda. And I think Jillian's next.
Wonderful. Thank you, Kari. I'm Jillian. I work for a statewide nonprofit in Colorado called Illuminate Colorado. We are a statewide nonprofit that aims to strengthen families, organizations, and communities to prevent child maltreatment. As I believe Monica shared at the kickoff to the session, our organization also convenes our state's statewide coalition focused on substance use and pregnancy. And so you might be looking at this slide and wondering why the location says Denver if we're really talking about rural communities. And so we have what I'm learning is a unique approach to how we're supporting this grant. Illuminate has had the honor of getting to work with a number of regional coalitions and partners around the state, really for a number of years. And when we saw the notice of funding come out, we really were having some conversations with one of those regional coalitions in the southern part of our state. And kind of through some of those conversations, that coalition asked if we'd be willing to take on really the administrative burden of the grant while flowing almost all of the grant award dollars to community members, really our consortium members, to actually do the work. So my organization, we're really offering facilitation, project management, support on reporting and data, that sort of thing, and really are really lucky to partner with, you'll see the consortium members there, who are really doing the work on the grant. In terms of what the service area is for this grant, so it is kind of central southern Colorado, a beautiful 6-county region. Any national park enthusiasts might be familiar with the Great Sand Dunes National Park, which is in the area. And really, this region in our state is experiencing disproportionate rates of neonatal abstinence syndrome, which is really part of the impetus for the work. And the partners on the ground have been focusing on this topic for many years and had lots of ideas, but just didn't have the funding. And so this grant really was kind of meeting a need there. Next slide, please. So you'll see our 6 selected strategies in our focus area on integrated care and care coordination. I'm not going to go into all of these now because I'll speak to many of them in more detail as our questions kind of come. But I did want to share some of the main activities that these strategies really hinge on for our effort. And so some of these kind of cut across multiple strategies, but certainly planning around some anti-stigma and stigma reduction kind of public awareness work, really doing work to address barriers to treatment. I believe Linda, right before me, was talking about childcare as one of those barriers. We're also really thinking creatively around offering co-located childcare using an innovative approach, and that'll be the movie trailer of a future question. And then also doing work to offer some multi-site co-located care coordination options. And so really creating some new roles in the community that can serve multiple points of entry, and thinking about kind of the importance of warm handoffs and supportive access to services in those transitions in care. And then lastly, really thinking about building capacity around both peer recovery supports and peer parenting supports, and kind of thinking about the intersection of those. So I'll leave it there.
Thank you. I love the movie trailer analogy. That's perfect. Maren, Dr. Voss.
Yeah, so I'm Dr. Maren Voss. I work at Utah State University, which is the land grant institution for this state. And if you're familiar at all with that system, we have extension offices out in all the counties in Utah, which is a largely rural state, except for that city center hub around Salt Lake City. And we're tasked with taking information from the Ivy Tower and bringing it out into the communities to improve lives. And so a little bit like Jillian was talking about, Utah State University has been able to, as we started to focus more on public health, be able to work with community partners and do some of the grants management aspects that really supports the work in our communities. And so I serve some of that role as well. So Twilley County is rural. I've been working there about 3 years. And we have this mountain range that separates us from the Salt Lake Valley. And so there's a few mountain roads that go across it, but for the most part, you have to go all the way to the end of the mountain range around the top of it in order to get over into the Salt Lake Valley. So if you make that trek, all of the treatment resources that are needed are there, and all the specialists that you would want are there. But moms, babies, and families really need that treatment closer to home. So I've been working with the Twila Rural Opioid Healthcare Consortium that was funded on an RCORP grant with HRSA. As we work with our partners, we were making a lot of progress on almost all of our goals except the NAS goals. And as we started to look at the why of that, we realized that there's really a lot of resources available for clinical training, but those resources really weren't being accessed. So just over in the Salt Lake Valley, they have this super rad clinic. They call it out of the University of Utah, which is our research institution in the state, where they have all the specialists for treating pregnant moms with OUD. And then there's also the NAS safety bundle that was referenced here at the beginning of our session. That became available, but it's not being accessed by our providers out in our area. And so the expertise is there, but we're not getting those resources into our area. The other thing we realized is that there's both a real need as well as a lack of family support services. And that's in a population that's really focused on families. So if you know anything about Utah, we have a birth rate that's about 30% higher than the national average. But at the same time, we're having big issues with neonatal abstinence syndrome. So we've seen about 275% increase in a decade in NAS. About 5% of our newborns are born with opioids in their system. And here's another scary statistic for Utah. Utah moms on Medicaid receive prescription opioids at double the national rate. And so there's definitely a need for more of these services. So with all that in mind, our consortium wanted to focus more on NAS because we weren't really being that successful in that specific target area. So they came up with a three-pronged solution. One, we're going to apply for more funding, which was great. We also brought 2 new consortium members over. And I actually go back to the last slide. And so you see our list of consortium members there. One of them was Warrior Spirit, which was a new treatment partner for our area, sponsored by our tribal partners in the area. And so they're an amazing partner in this effort. And then also Family Support Centers of Utah, you'll notice there, and I'll talk just a teeny bit about them here in just a second. So we got new partners. And then the third thing we wanted to do was focus on bringing family support services into our area. So if you go to the next slide, you'll notice right at the top, that's our focus area, is family support services. And you'll see here all those specific prevention, treatment, and recovery strategies that we selected for this HRSA NAS grant. But there's a little bit of a backstory as to the why of selecting these that I just want to mention. So as I mentioned, Utah's big on families. And so they have these family support centers, which is an agency that recognizes the need of supporting vulnerable families. They do things like they operate crisis nurseries, parenting education classes, just provide a lot of really useful targeted programming for families. And you can find them through about 80% of our state, but not in Tooele County. So we were able to have a combination of an agency with a lot of passion and a desire to come out into our area, along with some grant writing to support bringing these new services to our area, which was one of our big objectives. So that's something to know. The other thing is, as we thought about our grant goals, we knew that all those clinical training resources were available, but they weren't being utilized in our area. And we wanted to think a little bit as to the why of that. And we were guessing it was probably somewhat related to stigma. So we knew that clinical partners in our area still had a little bit of stigma around MOUD treatment. Just as a quick reference point, at one point when one of our providers had started to do medication-assisted treatment, he was being called the candy man in our area, even though he was doing evidence-based practices. So we knew that stigma was a little bit of an issue that we wanted to address. And we thought if it's there for your general patient population, it's probably even more so there for pregnant women who might need access to those services. And so we decided to, you'll see in some of these strategies, focus a little bit more on stigma reduction using social media campaigns as part of that. And then I'll talk more about that as we get into some of the specific questions.
Thank you very much. And actually, since you are off mute, I'm going to kick the first question to you to get us started. So if you want to go to the next slide, I'll just read the question. And then the way that we'd like to do this, appreciating that Zoom can have some awkward transition moments, is I'll kick the question off to a panelist to start, but then I hope the other panelists will unmute yourselves and join in the fun, and then we'll just kind of keep moving along and then invite audience to weigh in with their own questions and discussion after that. So we'll start with, what are the key resources and levers that you've identified to move implementation of your project forward?
Yeah, so as I got a chance to think about this question, one of the first things that came to mind, of course, was community partner engagement, and our community has been awesome with that. And it's really an area where HRSA helped put that emphasis by taking this consortium approach, because they've really learned that that was important in rural healthcare, to bring the limited resources we have together, to work together to meet the need in our area. But what I'm finding as we work with our community partners, it has very little to do with who I know, and it's everything to do with who they know collectively as a group. So we've noticed that as we start to bring resources into the area, those invitations get forwarded, the training opportunities get forwarded to others. And we've connected with agencies serving women and families in our area that we didn't know about existed previously. As just one example, we had a newer Division of Child and Family Services coordinator in our area that got one of these invitations for a training. And she had forwarded it out to people. And there was a group that helps support guardianship services that they work with and they refer to called grand families. They had been brand new to our Tooele area. Like happens a lot of times, places have an office in Salt Lake and then they'll get a grant or an opportunity to work in our different communities. And so they had gotten some funding to come to work in our area, but because of COVID, they'd never really made it out. Nobody knew who they were, but through this connection, we were able to connect with them. And now they're one of our partners in trying to make sure that women and children in recovery are being supported. So just that kind of extension of the network has been super powerful. In a similar way, this DCFS instructor had, I mentioned the Super Rad clinic that addresses pregnant women and SUD in the Salt Lake Valley. She'd been at some conference where she'd seen one of those people present. And so when we were talking with her about how we could address the need in our area, she had mentioned that really powerful training. She called it transformative. That, I mean, she wanted her employees and staff to understand that this medication-assisted treatment was, really the best solution, and that there wasn't any reason to have stigma behind that. And so we've been able to set up a training opportunity with that presenter from the Super Rad Clinic, a clinician who can come out to our area. And there was such an amazing response. That, we've just had agencies saying, I want my staff trained, I want my staff trained. And so again, it's not, I didn't know about this specific trainer at the Super Rad Clinic, even though I knew about the clinic, but through these partnerships, it's who they know that's really being powerful. And I'll just mention one other quick thing. There seems to be this synergy or aligning of the stars that is bringing opportunities and resources together as we start to focus on neonatal abstinence syndrome. I think that people in general are recognizing the importance of the topic. So the state level initiatives, the safety bundle that was mentioned, that came to Utah, the Utah Women and Newborn Quality Collaborative created a protocol specifically for pregnant women and substance use disorder. And so they're starting to do an echo training around that safety bundle. But in our prior consortium work, they had done an echo that was specifically just about opioid use disorder and harm reduction. And we had found that there were none of our Tooele providers attending those echoes. So we did a training at the hospital where the doctors were just a quick 15 minutes is all the time they could give us to let them know about the echo and that they could participate. From that effort, we got one Tooele provider to participate, which we thought was great progress. But now around this NAS echo that's just started, and if you don't know what an echo is, it's like a virtual grand rounds that they do for clinical providers to provide them with information on a specific topic. So around this new echo training opportunity for our clinical providers, we have no Tooele clinical providers participating yet. So there's the trainings there, it's available to us. And now as we have this opportunity to focus on it as a local consortium, we're gonna make sure our providers know about it and boost the number of individuals in our area getting trained. So there's some synergy, there's some great partners, and that seems to be the drivers for our success so far.
Nice. And I see, Jillian, that you weighed in the chat, so I'm gonna kick it to you next, just to.
Yeah, I found myself nodding, maybe embarrassingly a lot as you were talking, Maren. I think we really found that leveraging those other existing efforts has really helped our consortium think about how these resources can really be for local implementation and kind of getting the benefit of some of those other statewide projects that have maybe paved the way, I guess, for jumping into action sooner. We've also found that connections to those other health service delivery projects like the AIM OUD bundle, like some of our partnerships with our perinatal care quality collaborative in our state and some of our perinatal provider focused work around substance use and pregnancy. We've also found that kind of tapping into public awareness campaigns that have more of a statewide focus, and then thinking about how through this grant really making those relevant and visible in our service region. And then I just one other piece, because I don't think it's come up yet. has been around connecting the dots with our state's implementation of the Child Abuse Prevention and Treatment Act requirement around plans of safe care. Colorado has really taken an approach that's thinking about how human services can really be partnering with healthcare providers to be offering supportive options outside of the child welfare system for families impacted by substance use. And so again, kind of tapping into that broader network has, I think, been helpful in thinking about those other places of value add. I'd say one other thing is our consortium has really spent much of our planning period not only looking at the data and kind of needs assessments and those sorts of things that already exist, but we've also been doing some of our own primary data collection, including kind of key informant interviews with pregnant and parenting folks with substance use disorders in the region to really understand, like, we think we know what the gaps are, but do we really know where the gaps are? Like what would have really made the difference for individuals? And so we're still in the throes of doing that, but we found that it's been really helpful to not only build on what we have, but to get a little bit more data to help fill in our picture of where is the warm handoff need to be strengthened? Where is there need to be support in getting from birth hospitalization to that kind of community family support provider, that sort of thing.
And I'll just mention also around that data collection piece that I think that is an important part of moving things forward. That was another synergy for us. That Super Rad clinic I mentioned in Salt Lake had just done a provider survey on attitudes of clinicians toward medication-assisted treatment during pregnancy. And we were able to just take their survey, get it through our little IRB approval process, and deliver it to the providers in our area. And we'll have that as a foundational data point, both to inform what we do for providing some additional support and training, but also then to see if what we're doing is having any impact in a couple of years. So I agree that that's an important part of figuring out what actions we really need to be taking.
Love that. And I know we do need to keep moving on these questions, but Linda, Colette, do you all have anything you want to weigh in on here before we move to the next question?
I'll keep it really brief, but just kind of wanting to piggyback off what you said, the importance of networks and aligning of the stars. We happen to have an opportunity to do a network planning grant. And so we did form a community network that was new to our area. So it was the Sisseton Area Health Network. They have been very powerful within just learning about each other, learning about the roles they play in our community. And like you also mentioned, just communicating that onto their staff and their organizations have been key. So just kind of piggybacking off on that, on how important those community networks are to our project.
Thank you. That's great. Linda, anything you want to add?
I just want to thank Jillian and Maren and Colette for sharing, because it's really exciting the work you're doing. I'd love to know more about the survey of providers that you're doing, because that's something that we also have plans for. And yes, Jillian, you know, we are also working here in South Dakota on the warm handoff, and it's just exciting stuff. So thank you so much. I want to stay in touch with everybody.
And I do think that is the challenge of these questions, is they really generate the heat in terms of what's happening with your projects that's gaining momentum. So if we can go to the next question. We know that stigma is one of the most significant barriers facing pregnant and parenting women with opioid use disorder or substance use disorder, especially in terms of accessing care. How are you and your partners addressing this challenge? And we're going to start with you, Linda.
Thank you. This stigma was an area that we knew we had to address. And actually, this grant has provided us a great opportunity for that, because it is an area that impacts prevention, it impacts treatment, and it impacts recovery in our communities. And so we're looking at that really with education. We've learned, because as I said, we have no residential treatment facilities in the Crow Creek community, and we have no MAT waivers. So there's such a need for outpatient services and have providers, medical providers, really take a role in treating substance use disorder and opioid use disorder. And we recognize that providers, without even realizing it, can impact the stigma that is happening for the moms that we serve. And unfortunately, we've seen in our area, in all of our communities, tribal communities in South Dakota, we've seen moms who are not seeking treatment because of stigma. And we have such high risk for poor pregnancy outcomes to begin with, that we can't have that. We can't afford that. Our babies are sacred, and our babies need moms to really be comfortable seeking treatment. We've also learned that providers don't always feel confident in talking with mothers about their substance use. And so we wanted to make changes in that. So through education, through trying to really build a community that is aware, from tribal leaders and the judicial system to providers in the healthcare facility to everyday community members in the community. We want to develop a real understanding of how stigma comes out for the families that we serve, for providers, in so many ways. How can we change the language? How can we change the view of what recovery looks like? How can we reduce that stigma, because we know it affects the seeking of treatment. We know that it affects after treatment, the ability to really be successful in, and I like the word remission as opposed to recovery, really, because if we start to look at substance use disorders from the perspective of it being a chronic illness and not a choice, we start to take some responsibility for that, and we see that that is the evidence base. That is what we really know about substance use and about recovery. We would never say to a diabetic, why don't you just stop? But yet we do that to people who are struggling with substance use and opioid use. And so changing those stigmas it impacts every aspect of what our plan is with this grant. And we expect to do it by education, building really a community, at many different levels that are aware, and that the messages are the same. I think that's really important too. We can't have a behavioral health provider giving one message and a medical provider giving another message. The message is about the best practices for treating substance use disorders, the best practices for preventing neonatal abstinence syndrome, the best practices for building a recovery community. That message is the same for the entire community, and that's really the impact that we want to have in.
Yeah, I
in the
appreciate,
Coteau
oh,
region.
sorry, go ahead. I was just going to say, I appreciate you acknowledging the different layers and how consistent you have to be with messaging. But go ahead, Dr. Voss.
Oh yeah, I was going to echo her sentiments on education being a big thing in breaking stigma. I also noticed that like connection with people in recovery is part of it. We all have those similar recovery community goals that are, I think, going to help with stigma. But as we were setting up one of our trainings, the addiction specialist who was doing the presentation apparently always has a prior patient tell their story at the beginning. And this is a little quote from one of the people who'd attended that training. She says, "It was truly a heartfelt experience. It makes you reconsider everything that we were taught and wants you consider the way you treat and care for patients." Anyway, a little bit, direct quote, misspeak there, but it was transformative to hear the story of a patient. And then in one of those presentations yesterday on consortiums and how they run them effectively, one of the groups said that they always start with a personal story of someone in recovery. And I thought that's such a great idea because those personal stories are transformative and stigma breaking. And so I think that connection is a great example. And from this training we had that was successful, I'm going to start to include more of that to reduce stigma as well.
I love that. I love that. And of course, teaching through storytelling is a native way. And so that's beautiful. Thank you for sharing that.
I wanted to see if Jillian or Colette had anything you wanted to share about stigma before we move to the next question.
I'd love to hop in and on this kind of storytelling thread, so to speak. And so in Colorado, there's a lot of kind of moving pieces around stigma, anti-stigma and stigma reduction training that's happening in the state. And our consortium really saw an opportunity around more kind of norms change campaigns that are more focused on the community level. And so we're really lucky in Colorado to have a statewide campaign that was unveiled last Mother's Day called Tough as a Mother. And it's really focused on celebrating pregnancy and parenthood, and really the grit that is needed to do that while in treatment or maintaining recovery. And so that campaign is really implemented at the state level through our state's single state agency for substance use, as well as our managed service organizations. And so during our planning period, one of our work groups that's focused on these strategies for our grant met with the region's managed service organization and the firm that's lead on that campaign to discuss opportunities not only to bring more swag, so to speak, to the region. And so think like one of our ideas is to bring stickers that say Tough as a Mother and kind of lead folks to the website to put those on water bottles that are being handed out at harm reduction programs, and to put some of the posters and flyers on the hand sanitizer stations that at dollar stores and grocery stores and dispensaries, and kind of those places that we know are where people of reproductive age and pregnant and parenting people are. But we've also talked about possibilities around creating new campaign content that would really resonate more deeply with our 6-county region. And so we're still exploring what those could look like. And so that might look like some transcreation of campaign content into the indigenous languages in the region. It could look like some new storytelling opportunities for pregnant and parenting people in the region. But we're really excited about that part of our work, and kind of are lucky that there's kind of already designed campaign materials, and the costs to bring more of it to the region are pretty feasible.
Nice. That's exciting. Those are great ideas. Colette, anything you want to add?
Oops, thank you. No, I think I'm good. They covered a lot of great stuff. You guys are doing great work.
Okay, thanks. Well, and I did want to acknowledge Dr. Lopata's question in the chat. And so before we switch to the next question, I did want to just kind of note it says it's inspiring to hear about the incredible work that you're doing in your region, states, and communities, and how useful the AIM bundle has been. Do you know, do any of the panelists know if your networks communicate or work with your state Title V offices, the home visiting programs, or Healthy Start communities? A couple of you answered, but I wanted to open that up for the panel to respond to.
I was a quick response of, other than the AIM OUD bundle, I wasn't familiar with the others until his presentation. So Aaron's presentation. So that's one of the great things about coming to these conferences and these sessions is I learn about all these resources that I need to bring back to my community. So thanks for sharing those.
Yeah.
But I don't know about the other panelists.
We definitely use the Bright Start program a lot in our area. It's a very successful program. The visiting nurse that is tied to the program here in our area does a great job with that. And if anybody has that in their area, I would definitely suggest reaching out to them. It's a great resource.
Yeah, good suggestion.
I would really recommend the resources that Dr. Lopata gave on the Healthy Start Epic Center website, the A-STEP program. We were blessed to be asked to help produce those resources here at Great Plains Healthy Start. And we actually visited in some of the film work that was done from this reservation, the Court Creek Reservation, where our in-court grant is serving. And there are lots of opportunities that could really be used by anybody for teaching and working toward prevention in a staff meeting. Those resources are a great opportunity to really get this information and these messages out to just about any staff member who is interested in this topic. So I highly recommend the A-STEP resources. Thank you. And I was really pleased that you shared that, Dr. Lopata. It was awesome.
Yeah, that's such a nice perspective. And Dr. Lopata, feel free to come off mute if there's anything you want to say in conjunction with that or about anything.
No, well, I'm just really happy to hear that the AIM bundle is helpful and the ASTEP. And thank you so much for working on that, because I agree, it's a tremendous resource. But also, if anybody, please always feel free to reach out to me if there's any interest. And I mean, Title V obviously is in every state. It's always good to have relationships with them. They have a lot of community or public health workers, including nurses on the ground. Maybe they can, they're all about systems and linking people to care, which is so critical in these networks, as you guys have all done, and you're already doing an amazing job. But just knowing about these other resources out there that focus on this community of women, and but having other resources that also focus on the same community of women and children, I think is really valuable to have. So, Title V, home visiting, there may or may not be a home visiting model working in your communities, but if there are, they are working with the highest risk people. Same thing with the Healthy Start grantees, though there aren't as many Healthy Start grantees, so they may or may not be in your community. But particularly with every state has home visiting grants, though. So if there's a home visiting group working in your communities, they're working with the highest risk families, mothers, and there's a chance that they could be experiencing or be at risk for opioid use and risk for their babies to have NAS. And so just for you guys to be aware of that, there may be in communities. And if you're ever having any trouble connecting with them, please let me know, and I can help facilitate that. Just to make sure everybody knows of everything that's going on and available, all their assets you have. So it always helps to help link that together to strengthen your networks. But no pressure at all. But if anybody's interested, please let me know.
That's awesome. Thank you so much. And Sue, see you're putting in the chat the Title V profiles for states, the link to that. So thank you very much. And I did want to also, before we move to the next question, give a shout out to both Sue and Theresa, the other TELs that work with this cohort and the work that you're doing, kind of managing the chat and questions and helping things move along. So thank you. And you guys can feel free to jump off mute as well when you want to weigh in on anything. But let's go to the next slide and the next question. And Colette, I'm going to kick this one to you first. What best practices, and that's in quotes because it's a loaded term, implementing or planning to implement for this population of focus, and what outcomes are you aiming to achieve? Recognizing that we are in planning mode, and so some of those outcomes may still be being established.
Sure, there's so many best practices that, you know, I'm sure all of you and we plan on implementing throughout our process, but I decided to kind of just focus and point out one that we are definitely going to be implementing, and it kind of just comes from our structure that we are an actual healthcare facility and we work very closely with Indian Health Services in our facility. And so pregnant moms are either being seen at the Indian Health Service for their prenatal care, or some of them do see us here at our facility, but most mothers and babies at our facility. So again, we are looking to use some best practices to develop a consistent and common system of care between the two facilities. And that is going to be around using a validated screening tool to first identify the women at risk. You know, that's going to be the first part of any process.
And unfortunately, we have a little bit of a delay.
Determining who's at risk, and then the severity of the. Okay, can you hear me now, Kari?
Yep, and it might be necessary to turn your video off. I'm not sure. Just keep going. We'll get through.
Okay,
you just hang up every bit.
Okay, so just kind of backing up a little bit. So it's to be using a validated screening tool is important. Again, first identifying those mothers at risk. Sometimes that can be hard in building relationships and
there's always something in Zoom, isn't there?
assessment and determine, you know, is a brief intervention what's necessary? Do I need to refer them to different care? And what would that process look like? And do they agree upon those processes? Then we would also, like I said, determine, we have also developed a outpatient program within our care system called Compass Care. It's a care coordination program where we are delivering substance use treatment to patients. Again, and kind of looking at that whole well that they might need.
Colette?
And then also determining, like I said, if they would need an actual treatment center.
So thank you so much, Colette. And I'm sorry we missed a little bit of what you said, but I think hopefully we'll be able to circle back as we get into panel discussion. Your audio continues to hang up just a little bit, but I think we got the bigger part of what you said. And so thank you. Anybody else want to kind of jump in and respond to this?
I'm happy to jump in and follow through on the movie trailer promise I made earlier as well. So definitely leaning into the quotes here in thinking about best practices, because I think our consortium is really looking for kind of innovations or adaptations of things that are really kind of have an evidence base or have some kind of established promise. One of those pieces is probably, we've probably all heard the phrase, meet people where they are. And we're taking that really literally and thinking about mobile services and like really physically bringing things, meeting people where they already are. And one of the ways that we're doing that is around childcare as a barrier for folks to accessing treatment or recovery supports. So there has been a mobile preschool model in a different kind of rural part of Colorado that's had some success. So really retrofitting a school bus into a preschool classroom and being able to serve multiple communities in kind of that spread out rural setting to increase pre-K access. And so through this grant, we're actually planning to take that idea and tweak it in a few ways. And so we're really seeing one of the largest needs around infant and toddler childcare spots. And so we are retrofitting RVs to be licensed infant and toddler classrooms. So we're working with childcare licensing partners at the state and local fire departments and lots of partners to make that happen. And then really those mobile classrooms are able to serve parents at those kind of either high risk moments and or in ways that are eliminating that as a barrier for someone to take care of themselves. And so we're still very much planning what that will look like, exactly where that mobile classroom will be serving in the community, and kind of having to figure out the time to drive across 6 counties takes a significant amount of time. But really that idea of we don't want concern about a kiddo having a nurturing, developmentally appropriate environment be the thing that's keeping a parent from getting care that they need. So we're really excited about that part of the work. One other kind of model I'll mention is around parenting support specific for folks in recovery. And so there's a research informed model for parent support called Circle of Parents. And for a number of years in the state of Colorado, we've adapted that model for folks who are parenting in recovery. And so it's not a recovery support, so to speak, but it's really getting at the parenting part of that, part of the equation for folks in recovery, and really based on the idea that a lot of general parenting support groups, because of the way stigma operates, might not be super supportive for folks who are parenting in recovery. And so to have that space where you really are with peers who get it, as well. So that's one of the kind of in our recovery work, things that we're planning around for our grant as well.
Well, very cool. And I would absolutely call that a recovery support. That's really exciting. Any other panelists want to jump in on this before we transition to the next question?
With our grant objectives, with family support services being the focus, some of those are related to parenting education type classes. So we just, for us, best practice means making sure that those are evidence-based programs and part of that implementation. We're also doing the same type of concern for validated screening tools that Colette mentioned, and having social service agencies and family support centers, having those available so that people know when they may need to ask more questions of a doctor because they're potentially at risk and needing treatment.
That's great. Thank you. Linda, anything else you want to add?
Can I ask a question of the other panelists? When I think of best practices, one of the things that comes to mind for me is the understanding that one of the best practices in treatment is medication assisted treatment for pregnant moms. And I'm curious as to how you're addressing that with the providers in your communities. What has the response been from providers as you look at that?
Great question.
For us, it's just trying to get our providers accessing those resources and trainings that are there so that they learn for themselves. Those are the best practices. But another thing we've done is some of the trainings we're doing, we make sure it's an addiction specialist so that they're speaking the same language and they feel like they can trust the source of the data. So it's not us as public health prevention kind of people lecturing doctors on what to do, but it's coming from a source that they feel comfortable hearing from.
Important point. Thank you.
In Colorado, the San Luis Valley, the region for this grant actually was the area that kind of pioneered and pushed the rest of the state forward when it comes to medication-assisted treatment for folks who are pregnant as well. And so our challenge is a little bit different because it's been more thinking about continuity and sustainability. One of the provider who really was kind of the pioneer in our state on that did recently retire, much deserved. And so really thinking about kind of what does that look like continuing forward as well, but a slightly different part of the challenge there.
Thank you.
All right, let's hit the last question so that we'll still have time for participant discussion. If you want to go to the next slide. And Jillian, we'll have you kick this one off. How are you engaging providers of maternal and child health services in your project, and what challenges are you running up against?
Yeah, so in a lot of ways, this engagement was an immediate strength of the local work, given the number of years that the San Luis Valley Neonatal Task Force had existed and had already been convening maternal and child health partners in the region on this. So really lucky to have the region's only birthing hospital kind of represented and the main healthcare systems in the region kind of at the table, part of our grant writing, that sort of thing. But I would say in terms of challenges, I mean, we haven't talked about COVID yet, but COVID and capacity strains have certainly made making sure we had all of the right players in all of the meetings difficult, just because of all of the different directions providers are being pulled in. And so we've really found it helpful, kind of building on the keynote yesterday, talking about adaptive leadership and consortium models, to have work groups has been really valuable so that we can kind of get the right people in those smaller group conversations to be engaging those maternal and child health providers in that space, versus maybe a meeting that's a lot more update heavy. It is maybe less the best use of their time, but if they have 1 hour in a month, they'll come get their hands dirty with the work plan or write the job description for a grant funded position or that sort of thing. So that's been a challenge, and would love to hear other panelists or other attendees' ideas about the strain that COVID is placing on the health system and just the best ways to navigate that.
Really good. Glad you brought that up. Any other panelists want to jump in on that?
I really don't have any good insights. We have our local hospital that does our main outreach to our clinical providers. And so we don't have like a lot of direct connection. But one thing they did advise us, which I hadn't thought of on my own, was the importance of working with targeting pediatricians a little bit. We'd been thinking about OBGYNs, but they're like that aftercare period is another vulnerable time. The moms want to be in recovery and doing better. And so maybe going through pediatricians is a good avenue. So I'll just mention that, but I don't have any great ideas generally.
And happily, there are some good resources around that engagement of that provider group that, you know, we have some on the resource portal, but I'm glad you brought that up, Maren. Thank you. Anybody else before we turn it over to participant in discussion? I think, Theresa, you mentioned there are some good questions coming through.
I think for us, and working in tribal communities, because we're so isolated and because there is a shortage of resources, one of the things that we are looking at is who are the quote unquote providers of maternal and child health services. You know, we have other programs, like people spoke about McVie. We have a tribal McVie, for example, in Siston, South Dakota, where Colette is from. And there are some services that they are providing. You know, you can do a screening, you can check blood pressure, you can this idea of really a collective impact view of screenings. It's recognizing that providers of maternal and child health services are not only the hospital or the clinic. There are lots of people in that community that are providing various levels of those services and coming together. We need to come together. I use the term again, reducing silos, but for our tribal communities, that's a very big deal. So it's because they're more isolated. It's not like you can be in a rural county, but we're really closed communities in some respects. And so we really have to look at that. We have to look at allowing our resources to serve the families that we serve as a whole. You know, if we can't get it done here, can we get it done there? I don't know if that makes sense, but
it makes tremendous sense. And I'm really glad that you added that nuance, that it's the maternal and child health goes, maternal and child service providers go far beyond just that more public health and medical care professional groups that we tend to think of first.
Exactly. Thank you.
Well, let's open it up to the audience. And Theresa, Sue, I don't know if you're seeing questions come through.
Yeah, well, there was one in particular, so I was trying to find it, just around someone had said they would love some more ideas on how to leverage some of the relationships and that Dr. Voss had pointed out. So I was just kind of looking through, and Dr. Lopata, so it was around the AIM bundle, but also the Title V. I think we might have addressed some of it, but I wasn't sure if there were other comments or questions around those relationships or resources.
Thanks. And I think, you know, with the participant count that we have, if folks just want to come off of mute and ask questions or weigh in with what's going on in your communities, feel free.
I think back to that, the Title V McVie office kind of piece, I think that's on our radar and thinking about potential sustainability avenues. And we're still in our 6-month planning period and haven't gotten to implementation yet, but it's never too early to think about sustainability. I'm sure like many states, behavioral health related maternal deaths are one of the things that's really driving maternal mortality in our state. And so have had the chance to have some conversations about how that's reflected in Title V investments in Colorado and kind of where we are in our state's kind of needs assessment and doing those priorities for local public health agencies. We haven't figured out the right way to connect those dots yet, but are really thinking that there's going to be, I think folks were saying earlier, a lot of like aligning of stars was the terminology we were using. So I think we're hopeful that there'll be something like that, but again, would love if there are specific ideas or opportunities folks are seeing about how to make sure those things connect, would love to hear them.
I'm an old person, but I have a young project coordinator working for me who's just a little bit unabashed about just asking people for help that I just love. So we had heard about a connection and now have a Virginia Commonwealth University professor who likes to support agencies in their social media campaigns. He's a communications professor. And if they're doing good work, he's happy to help and has the resources to help. So he's guiding our social media campaign and providing expertise that I wouldn't have imagined possible for our small team just because somebody was willing to ask. So I like the idea of, in terms of engaging other people, like part of it is I've got these connections as other people in the network let me know about people, but then there's also a little bit of being willing to ask that I think helps move things forward.
Thank you. And there's a question that came in from Huva asking, are dads involved in any direct services?
We did not write dads into any of our planning. We do have in the state of Utah some really good fathering, parenting initiatives that come out of Utah State University and a lot of grant funding around that. So we don't always ignore dads, but for the NAS grant focus, I didn't think to include them. Anybody else?
We will include dads in the work that we do on recovery communities. Healthy Start has a fatherhood initiative, and some of the other programs in the community have fatherhood initiatives. Our providers at the IHS facilities certainly encourage the involvement of fathers in perinatal care with moms and children. One of the things I think about when I think about recovery is families dealing with a child who has been exposed, has experienced neonatal exposure, and what it's like parenting that child. And so we would encourage that both parents be involved in that experience, and how dads can support moms who are in remission or in recovery after baby is born. Like, parents really need to know what are the challenges of a baby who has NAS. And so because in all of our communities, including Crow Creek, we're actively engaged in work with fathers. That will be part of our plan. Again, education. So
Excellent. And I think that the plan of safe care is another opportunity.
Yes.
We don't have time. We're wrapping up, and I see one more question in the chat, which I'd like to get to. But that is I wanted to point that out, that plan of safe care opportunity is there as well. Is anyone seeing or using an app to help put pregnant parenting people in recovery with peers?
We are not, and I would love to learn if others are, though, because that's been part of what we've been exploring in our primary data collection, especially with folks with lived experience, of if there is something like that that folks are finding meaningful, but we haven't found it yet.
Just let people know that MCHB did do a challenge like for a prize, and one of the challenges was to come up with an app that worked, that helped pregnant women who are at risk or have opioid use or are risk for it to better access prenatal care and other services. I didn't include it in my presentation because while we announced the winner, I tried to look up what's going on with the app. I didn't find a lot, and sometimes the winners don't always follow through and complete it. So I'm going to find more information and get back to you guys, though. All right, just so you'll know that if there's an app out there, because if the apps that we find, even if they weren't winners, they came in second or third place, if they're out there, I want to be able to share it with you guys. So I'll follow up and look at that and then get it back.
And we've also heard from a couple of our grantees that the Chess Connections app is something that's really been helpful for them around care coordination. Now, the question was specific to connecting with peers, but I think that that's an aspect of that app. I'm not familiar enough, but we could certainly give you some more information and follow up or find a way to connect you to more information. But with that, I want to thank our panelists so much. This was a really rich discussion. I really appreciate all that you shared about the work that you're doing and all of the creative and innovative ways that you are doing that work. So I could see the wheels turning as you all talk to each other, and just appreciate learning more about everything. I wanted to also note that UC Davis, even though they were not able to be on the panel today, does have a video available in the video library connected to HUVA, I believe. So you can go and check out a little bit more about their work. They've got an ECHO model, so it's very interesting, kind of different challenge. With that, I'm going to be quiet, and John, I'll toss it back to you.
Thank you. So everybody, and thank you to the panel for a great presentation. And we do have 45 minutes before our next breakout sessions start. If you'd like to take a break, that's fine. But I also want to remind you, we have the Grantee Partner Exhibit Hall going on next. You can click onto that, and there are live representatives standing by. This is the equivalent of when you're actually at a conference and walking into the room where all the tables are and talking to folks about their resources. So we do have some live presenters standing by at some of those virtual tables. So you'll see a little green camera that says someone standing by. And if you just click on that, you'll be able to get through and talk to the person manning that virtual table. So enjoy your time either way. If you're taking a break or if you'd like to go through our exhibit hall, please feel free.